Well, welcome back to the main stage. In late 2020, 2020 Mom and the International OCD Foundation formed a partnership to close, I think it's rightfully to say, horrific gaps in provider, public, and patient understanding of maternal OCD and intrusive thoughts. This next panel is going to share the culmination of our 2 years of work with you. To moderate the panel is Dr. Mary Kimmel. Dr. Kimmel is a psychiatrist and assistant professor at the University of North Carolina at Chapel Hill and director of the program's Perinatal Psychiatric Program. She has led some really interesting research, which I encourage you to check out, including looking at biomarkers to detect maternal mental health disorders and the role of the gut biome. She's also co-led important research in postpartum OCD. And with that, Dr. Kimmel, welcome to the main stage. I'll turn it over to you.
Yeah, thank you, Joy. I'm so excited that we're going to be talking about this today. In fact, I literally was just responding to an email about screening for symptoms in the perinatal period for pregnancy and postpartum, and trying to advocate that we really need to, that some of the screeners that we most commonly use, like the Edinburgh Postnatal Depression Scale, is great, and that it's really good that we've gotten so much out there about depression, but that we also need to be starting to think about how we can get people to talk about perinatal OCD. So we're going to start with having our panelists introduce themselves. So we'll start with, I see John first. So having John and then Kate and then Stephanie all introduce themselves.
Thanks, Mary, and thanks for including me on this panel. I'm John Abramowitz, and I'm a clinical psychologist, professor at the University of North Carolina, and collaborator with Mary Kimmel on an awesome project that I hope we have a chance to talk about later on.
And I also want to say Cindy also will be there too.
Hi, I'm Kate Destefano Torres. I'm a professional counselor based in Southern New Jersey. I am the founder and director of the Artemis Center for Guidance. We specialize in maternal mental health and obsessive compulsive disorder.
Hi, everyone. My name is Stephanie Kogan. I'm the program director at the International OCD Foundation. We've loved working with 2020 Mom and are excited to be here today to present to you all.
Hi, everyone. I'm Cindy Herrick from 2020 Mom. I'm the Strategic Partnerships and National Campaigns Lead, and also the project manager for this wonderful collaboration with IOCDF.
Great, thank you all. So we're looking forward to hearing more from all of you. So John, please, to start us off, can you please describe to us intrusive thoughts, which are actually a key component of obsessive compulsive perinatal OCD?
Yeah, sure thing. So all of us, whether you have OCD or a baby or expecting or not, or a male or a female, but if you're a human being, you have thousands of thoughts a day. And many of those thoughts are really useful to you. You know, how do you drive your car? Where are you going? How do you balance your checkbook? You know, whatever. But then occasionally we all get thoughts that are senseless, and sometimes they're downright unpleasant, and they're about, you know, awful things or awful topics that, you know, you really, maybe you don't want to think about, maybe you don't want them to happen. But as human beings, you know, we all have unwanted thoughts from time to time. And these might have the content of, you know, like I said before, it could be something, you know, terribly immoral, thoughts about what if I harmed someone, what if I, you know, insulted someone. They can be unwanted sexual kinds of thoughts. They can be thoughts about what if I'm, you know, contaminated, dirty, what if some accident, what if I caused some sort of accident. We all have these experiences. For most of us, most folks, these thoughts just kind of pass unceremoniously, you know, kind of in one ear and out the other, if you will. When people have obsessional problems, you know, OCD, or even kind of on that, we know that OCD is a spectrum. It's not just you either have it or you don't, but there's, you know, different levels of it in the community. When people struggle with these kinds of problems, they're having intrusive thoughts that they interpret as being significant. They misinterpret them as being really important instead of just being, you know, mental noise like they are. And they start to respond in certain ways that make the thoughts more important. So for example, I'm bathing my child and I get some sort of a sexual thought about their genitals or something like that. And I have a choice. I can either see that thought as just a senseless thought, well, whatever, it's going through my mind, or I can see it as, oh my goodness, this means something terrible about me. Maybe I'm a child molester. Maybe I want to do something terrible. Maybe it's some sort of deep-seated idea. Maybe I should avoid bathing the child. And turns out that when folks go down that route, that leads to more problems. They become preoccupied. The thoughts take up more and more space in their mind. And I hope we have a chance to talk about more of that later on.
Okay, thank you, John. That was great, and a great kind of intro to, I think, thinking about that, and particularly thinking about kind of that unique aspect of perinatal OCD that may even make it something that we don't commonly ask about, but we need to have this conversation. And so now it'd be really great to hear from Stephanie to tell us, to explain OCD and to tell us more about kind of perinatal OCD and
Sure,
how
yeah.
in comparison to OCD and similar and different.
Of course, yeah. And John actually got us started there. I don't know how much I have to add on to his intro to OCD there, but OCD is obsessive compulsive disorder. So we have the O is for the obsessions, which is the intrusive thoughts and things that John just outlined so eloquently. The C is for compulsions, which is the behaviors that sometimes they're things you can see. A really common example is hand washing. I think everyone's familiar with hand washing when it comes to OCD, but they're not always things you can see. Sometimes they're things in your head. Maybe someone will do, say a prayer a certain number of times to themselves, or has a special word they'll say just to make the things that they're worried about, the things that are causing them this fear, distress, anxiety, disgust, bad feelings, go away. Or neutralize or get rid of entirely. So, and the D is something we at the foundation are always stressful. The D stands for disorder. And that just goes to indicate that, as John said, everyone has intrusive thoughts, but not everybody spends hours a day caught up in this cycle of, I have these thoughts, I can't get rid of them unless I do my compulsions. And then the cycle starts back up again. And it just really gets in the way of people being able to live the lives they want to live and kind of lean towards their values and all of that good stuff. So there's so many different subtypes of OCD that it'd be impossible to talk about them all. And I sometimes feel like a new one is discovered every week. But some of the most common examples of obsessions are about, causing harm to others. So I think if we want to use some maybe perinatal related examples, I'm really worried I'm going to hurt my baby. So compulsions around that they could be avoidance. They could be not wanting to go near the baby, not wanting to hold the baby or be alone with the baby. Another example, if we're going to use perinatal OCD, John mentioned the sexual intrusive thoughts. I'm washing my baby, I see the genitals, I maybe have a thought, oh my gosh, I cannot possibly wash this baby anymore. Somebody has to wash the baby, because if I wash the baby, I will do something horrible and something horrible will happen. There's, worries about contamination, again, is a really common one. So worries that the baby's going to get sick or die, or I'm going to get the baby sick and die. So we may do a lot of hand washing, a lot of laundry of their clothes, sterilization of bottles, things like that. And honestly, the key difference between, and I wouldn't even call it a difference, to be honest, but one of the main ways you asked about distinguishing OCD and perinatal OCD is just that the obsessions and compulsions in perinatal OCD tend to focus on the child, or if we're in the prenatal period, the unborn fetus. So that's kind of the big difference, to be honest. And there's been some research that we'll get into later about OCD that people have in this time period that doesn't have to do with the baby, but I think more often than not, we are seeing it have to do with either the baby or the unborn child.
Yeah, thank you, Stephanie. That was great. And I completely agree that it's good to think of it as an umbrella term, and that way thinking about that there are individuals are all going to have kind of unique maybe components, and also the point about the behaviors, and really that kind of taking what John was saying and moving that to continuing to kind of get those thoughts even more embedded, because you're now trying to have these behaviors to kind of make you feel better, but they're actually making you get stuck. And also what you were saying about, I particularly like the thing about contamination, but I think that's also what makes it so hard, is because I've had moms who've had preterm babies and they've been told, if they get sick at all, it's going to be horrible for their baby. And so then it's hard to know what is actually, maybe irrational and what's not rational, and so kind of thinking about all those things, I think now we want to bring it to personal experience, and really understanding how these things, kind of taking them from the more academic to really understanding how they affect us. So Cindy, please share some of your personal experience.
Yes, so I'm going to go a little bit back and kind of set the ground a little bit. I think my story might be a little bit of a departure. As Stephanie was saying, it's kind of hard to pinpoint, perinatal OCD into like one particular area. And I think I fall under that category. And so 10 years ago, I was pregnant with my son, and throughout most of this last decade, and through most of my work in maternal mental health, which is about the last 7 years or so, I always thought that I suffered only from perinatal and postpartum depression and anxiety, mainly capitalized by, suicidal ideations, being suicidal, and severe insomnia. And I'll get back to that here in a second. But, so imagine my surprise when I started working on this project 2 years ago with IOCDF, and, the wheels in my head started turning, and I realized, like, the more I learned about perinatal OCD, that I actually had perinatal OCD, in addition to the depression and anxiety. Now, which one came first and which one came later, that's debatable, and I still have work to do on that. But and I was actually really, really, really surprised, because for years I thought I knew what perinatal OCD looked like. What John said about it, usually it revolves around baby. There's something sexual, I'm going to hurt the baby, or things like that. Mine actually happened while I was pregnant, and it did not involve the baby. And from what I know that the spectrum of perinatal OCD is so incredibly vast that even if you don't fall into the commonly talked categories of it, you can have the obsession and the compulsion. And so, when I was first asked to speak about this, I was a little hesitant, because I went to Kate and I went to a few other people where I'm like, I don't know if I'm the ideal person to talk about this, because I don't feel like I fit into this what it should be. I was never formally diagnosed. Like OCD never came up while I was pregnant, and I have a history of depression and anxiety. So I have a psychiatrist, that never came up. And I'm like, am I a good representation, of lived experience if I was never officially diagnosed? And, Kate kind of talked to me a little bit, and she said, on average, it takes 14 to 16 years for someone with OCD to be properly diagnosed. And this is for general OCD, which, perinatal OCD is just kind of coming up, and the awareness of it is much further behind just general OCD. So I can imagine for perinatal OCD that this average timeline is probably a lot longer. And that actually made me feel a lot more at ease, that what I thought was not normal was actually a great example of why there is such a severe gap in this area of perinatal OCD. And so earlier, Dr. Bronowitz and both Stephanie, they talked about intrusive thoughts and, the difference of like OCD and how it sometimes can be confused into other things. So going back to my story of feeling suicidal while I was depressed, I always thought that I had suicidal ideations while I was pregnant and depressed. But now I know that what I had was perinatal OCD with intrusive thoughts about suicide. And I had never heard about that before, like never, ever, ever. And I have this very vivid memory, and I share this every time because it scared me so badly. When I was 7 months pregnant, I'm driving to the drugstore, and all of a sudden there's this horrible thought of, what if I kill myself? What's going to happen to baby? What's going to happen to my family? Oh my gosh, what a horrible thing. I was so horrified by it that I pulled over and I started crying, and I didn't know what to do. And I never told my doctors because I didn't want to be locked away, and oh my gosh, am I going to get psychosis? And all these thoughts came along. I didn't know what intrusive thoughts were then. I really, really wish I did. And I now know that those were intrusive thoughts because I didn't want to die. I didn't want to hurt myself. I was horrified, and I'm sure we'll get into this a little bit later about, the difference between when it's psychosis and not, and when you have thoughts that are unwanted versus thoughts that you can't differentiate if they're real or not. In my case, I didn't want them. I did not want to die. I wanted to have my baby. I didn't want to hurt myself to hurt my baby. I didn't want to do all of that, but I didn't know any better then. So I thought, I'm thinking suicide, I must be suicidal. Oh my gosh, I'm suicidal. They're going to lock me up. They're going to take away my baby whenever I have him. And, it started going into this tipping point of from intrusive thoughts to perinatal OCD, because it took over my life to a point where I started developing the compulsions to help me feel better about the obsessions. And so the compulsions, looking back, I was talking to my husband about this yesterday. We laugh about it now, but it was very real at that time. I thought that if I was alone with my thoughts, then I would have these thoughts about suicide. So I did everything I could to make sure I wasn't alone with my thoughts. So I begged him not to go to work first because I didn't want to be alone. That obviously was not realistic. That didn't work. And so whenever I was alone, I turned on all the TVs in the house and the radios so that I couldn't hear my thoughts. And then I thought that if it got dark and I'd be alone with my thoughts, then I'd have these scary thoughts again. So then I slept with the lights and all the TVs on for the next 6 months. And when I did have the TV on, I couldn't watch anything that was remotely scary. And I'm a horror fan, so this is a huge deal. When I stopped watching horror films and like suspense stuff, all I did was watch cartoons because I somehow thought like the violence on it would make me think about these things. And so, it made perfect sense to me at the time, but I spent probably 6 months, the first year of my son's life, sleeping to Garfield and Scooby-Doo. And the plus side is I now know every episode of it. And my son's like, wow, you're cool. But, that really was how we lived for a while. So this work has been amazingly life-changing. I mean, both professionally and personally for me, because I know that there are other moms out there and dads and parents who may have these scary thoughts, and come to find out that with Dr. Abramowitz's research, and that 70 to 90% of new parents get these intrusive thoughts. And had I been able to label it right off the bat, I wouldn't have gone on this circle of just really a lot of terror and agony and distress. And so, now I'm like, I have so much more work to do. I thought I was completely healed, but I'm like, oh, now I get to look at this through this other lens where all these odd behaviors that I just tacked on with what I thought was just depression and anxiety makes a lot of sense. And it's a lot less scary when we are able to put a name to something and understand it. So thank you all for this great work and for letting me share my story.
Yeah, thank you for sharing that. Thank you. And you highlighted so many, things that are so resonant with, I think probably so many women and so many individuals going through this. And some of the things I want to just highlight. One, I think we always think about postpartum, but really we need to be thinking about in pregnancy too. And in some ways, I think sometimes we are kind of like, oh, pregnancy, it's fine. But it is important that we be able to have these conversations in pregnancy too. And there's some interesting biology that I think is your system's trying to protect you. And so that's part of what's happening as you're moving along through this process. And then, the things you said about suicidal thinking, I think, when we think about the screening we do, and we just kind of ask, are you having them or not? And it's really important to be having these conversations about, tell me more about it, and really having conversations around it and thinking, and that absolutely is, trying to understand that can be intrusive thoughts as well as, thoughts of really thinking about suicide. So those are all really, and there's so much more I could pick out from that, but now I'm going to have Kate tell us some about treatment, and particularly the treatments that she's using, such as ERP.
Thanks so much. I guess to start with ERP, I want to go back to something that Stephanie mentioned about the cycle. And I think that's important to understand. So what happens with the cycle is that there's this obsessional thought that causes great distress for folks. And then they will participate in either some physical action or some mental action or mental ritual to give themselves some relief from that. And they will get some relief, but it's temporary. And so what happens is then that just goes back around and that thought comes back. And I think John had talked about this a little bit too, that you get yourself into trouble there, because basically what's happening is you're not giving yourself an opportunity to learn that nothing bad will happen if you bathe the baby. Nothing bad will happen if you carry the baby down the stairs. And so that's what we try to do within the therapy. So exposure and response prevention is made up of two parts. The exposure piece is where we are creating situations where we can kind of trigger that discomfort for folks and help them sit through that discomfort so that they have the opportunity to learn that nothing bad will happen. And in fact, I think our culture kind of gets this concept anyway. If you think about sayings like, face your fears, or if you fall off the horse, get right back up again. So I think it can be an easy way to explain to folks, because I think, most third graders probably have heard those sayings and understand that if you are avoiding things that make you uncomfortable and scared, that you're not going to be able to get past those things. So we create these exposures, and we can do that in real life, in vivo, or we can do that through imaginal exercises. It's preferred that if you're able to do it in real life that you do, but there are some situations where you would not be able to do that. Examples that come up would be surrounding, harm OCD or pedophilia OCD. You can't have somebody act out abusing a child. You can have them imagine that and imagine the consequences of that and kind of get that distress sort of up and let them tolerate that. The second piece of this is response prevention. And basically what we do is we help folks identify what rituals they're participating in to relieve their distress. And then we ask them to self-monitor for those rituals. And we ask them to try not to participate in the rituals. And it's difficult for them, but we ask them right from the beginning, let's, just try the best you can to cut them out 100%. And we know that that's not going to happen immediately, but we want to aim high, because if we say 50%, then they might only do it 10% of the time, right? So we want to aim high. And by not participating in the rituals, people then can learn that the bad thing won't happen. And Cindy, I hope this is okay if I share a little bit about our conversation, but something that Cindy said to me last week when we were chatting about her experience was that she had to be with her baby. She couldn't avoid that. It just wasn't practical. Her husband had to go to work and she needed to be providing the caretaking. And that is ultimately how she ended up feeling better, because she was forced into those situations and it wasn't conscious, but she wasn't able to participate in her rituals because of that. And I think that probably led to her being able to work through those things. So that's the basic behind ERP. I don't know if you want me to get into a little bit more about sort of how we set that up and what that looks like. I'm happy to do that, but I don't want to ramble on.
That was great. I think that really got to the heart of this, that what I'm hearing from that is you're retraining the brain in terms of kind of, it's in this like high alert mode, and you're trying to get it to be like, things are okay, and in some ways getting to that, but to do that, you have to get to the high alert mode and get through it. And also I liked what you said about sort of even the imaginal ones, which seems counterintuitive to make someone go through and have to think about these worst case horrible scenarios, but it's almost like helping your brain realize that that doesn't make sense to me, that it's not, I'm thinking of it because I'm so protective that I'm actually going to this extreme of thinking of this worst case scenario, but it's like, so I think that was really helpful to help people understand the treatment, because I know, and I love the face your fears, because I know explaining this to patients, they're like, you want me to do what? And, but it really is really helpful. So that's great. And and hopefully we can have people, ask questions. And I know there's an option for people to ask us questions and we can answer them later. So if people have more questions about kind of the process, I think that's great. And so now we're going to have Stephanie share some of what are actually the two groups have been working on to really try to make this more part of a national conversation.
Sure. So as Joy mentioned, we formed, when she was introducing Mary, we formed this partnership almost 2 years ago at this point to start to try to figure out how to recognize that this gap exists and what are we going to do about it? How are we going to make it better? So we formed a task force, a perinatal OCD task force that is multidisciplinary. It has, researchers, it has clinicians, it has folks with lived experience. It has people from a variety of professions, whether it's the psychology world, OBGYN, et cetera, et cetera. And through that task force, we worked in 3 main subcommittees. So one was public awareness, one was clinical provider training, awareness and intervention, and one was research. So what I'm going to show you just now, it actually reflects the work of all 3 subcommittees in a way that I will explain. I'm not going to go too deep into it because our hope is that you explore it on your own and give us feedback. It was included in the handouts for this section, but let me just share my screen quick. All right, so what you are looking at is the Perinatal OCD Resource Center that we put together. So this, what you can find here, it's kind of a one-stop shop for info. We have a couple various categories you can click on to find out more about what it is, how it's treated. We have information for loved ones and supporters, resources for folks who do live with perinatal OCD. And then the one thing I will click through here is this clinical provider section, just because I want to show you, I'll have extra info for clinical providers here as well, including screening tools and assessment tools, more in-depth info about treatment, and then core competencies by clinical profession. So this reflects, again, I mentioned the work of all 3 subcommittees because the public awareness did a lot of these boxes, and I apologize, there's some sirens going by me here. And obviously the clinical provider group put together the recommendations for clinical providers. And then what the research group did, their big first undertaking was doing a literature review. And as I believe John is going to talk about shortly, there is the moral of the story is there's way more research that needs to happen in the perinatal OCD space. But they did pull together what we do know. It was a massive undertaking. And then the findings from that literature review are reflected in the various statistics and recommendations that are referenced throughout this resource center. So invite you all to take a look. We're super excited. This is certainly not the end of our task force work together. I know we actually just met earlier this week for the research subcommittee, and we're going to be publishing the literature review. And for those of you who are interested in seeing it, we're going to be convening a summit to see how, next steps in the research and kind of the translational world in terms of turning those research findings into clinical practice should go. I know the clinical provider group is really invested in figuring out how we can increase training in this space, whether it's coming up with our own training specifically about perinatal OCD or working in the many incredible trainings that already exist to just beef up what they do talk about perinatal OCD. And then the public awareness group is really going to turn their focus to dissemination and just getting the word out there and raising awareness. I know they've talked about, awareness campaigns they could run, possibly turning some of this info into maybe a waiting room poster, brochure, those types of things. So that's what we've done. We're excited to dive into these things a little bit more next, but watch this space because the work is not over and we're excited to continue.
Yeah, thank you for sharing that. I'm so excited. I know from being, the work that we've done that this was a lot of work that it's really great to see this and to be able to get this out there to all communities, helping individuals and their families. So now we're, and you alluded to this, so now we're going to have John talk a bit about the research. My favorite.
Mine too. Thanks, Mary. And as Stephanie pointed out, we have more questions than answers at this point, but I'll really briefly kind of give an overview of what we do know. One of the things that we know pretty well, and I think this goes back to Cindy's very vivid illustration of what she went through. We understand the symptoms of perinatal OCD. And, by and large, they're similar to what happens when you don't have perinatal OCD, just kind of regular old OCD, like what Stephanie described earlier on. The intrusive thoughts, however, tend to focus around the pregnancy or the child. The compulsive behaviors are about trying to reduce anxiety or basically put things right, reduce that thought, try to get a guarantee that nothing bad is going to happen. We know that, everyone, all new parents have intrusive thoughts about bad stuff that can happen to their baby. Mary, as you pointed out, that probably has a protective function. We're probably hardwired to think that way. But we do have some evidence that folks who go on to develop OCD tend to misinterpret the meaning, the significance of those kinds of thoughts. They catastrophize about those kinds of thoughts. We know that if a person has OCD and then they become pregnant, have a baby, they do have an increased risk of that OCD becoming more severe. And we also know there's a little bit of an increased risk for a first-time presentation of OCD during pregnancy after childbirth. And I should say that that happens in the moms who are delivering. It also happens sometimes in the partners of those people, whether it's a dad or a female partner as well. As Kate mentioned, we have an effective treatment. We have two effective treatments. One is medication, one is exposure and response prevention. We know they both can be helpful. We understand, as Kate mentioned, we understand why exposure and response prevention, even though it is a tough therapy, it sounds, pretty intimidating, but it works. And we know that it helps people to learn that they can manage these intrusive thoughts. They can manage risk. They can manage uncertainty better than they thought they could. And that's the whole idea of helping people to face their fears. We don't know very much about the causes of OCD more generally, and especially in the postpartum. We have some good guesses about biology. We have some guesses about psychological factors, learning factors, things like that. But it's much more complicated than just, it's either this or that. It's a combination of factors. And right now, Mary and I and some colleagues at Johns Hopkins, we're doing a long-term study, a 5-year study, looking at how do these biological factors, how do these psychological factors work? How do they maybe work together in terms of predicting who's going to go on and develop OCD. We also need to know more about the relationship between OCD and depression, as Cindy was mentioning. If you have a new baby, it's supposed to be, society says you're supposed to be really happy, and then the intrusive thoughts come, the normal intrusive thoughts come. Well, if you misinterpret those as being really significant, and this means that I'm a terrible parent, stuff like that, or something bad's going to happen, then you have that black cloud hanging over your head and you're going to feel depressed. And we know also that when people are depressed, they tend to have more negative thoughts. So there's probably a vicious cycle that's going on. Now we're looking at that in our study as well. The last thing I'll say is that we understand pretty well the differences between OCD and psychosis. And I think, Stephanie, it was you who mentioned before, having OCD, having intrusive thoughts about your baby does not mean that you're going to harm your kid. And I just think that there's so much misunderstanding around that. I know I have 2 daughters, they're older now, but when we were going to perinatal education classes before we had our first one, the educator said, if you have depression, postpartum depression, you get some help for that. But if you have unwanted thoughts about harm coming to the baby, that means you have psychosis. And I, being who I am, I stood up and said, no, that's wrong. Everyone's going to have intrusive thoughts. And the teacher didn't like that very much, but it's true. We know that we all have intrusive thoughts. We've said this throughout the presentation. It's what you do with the thoughts that's important. Psychosis in general is extremely rare, and postpartum psychosis is extremely rare. We do hear about those very unfortunate cases like Andrea Yates that, act on intrusive thoughts. But again, we can get into this later. There are very important differences between people like Andrea Yates and folks that have postpartum OCD. And it's so important to understand that and to not confuse those. So I will leave it there before I get the cane.
I think that's my job. All right. John, that was great. And it definitely brought up, I like the thinking about it. We really do need to be thinking about this with the kind of the psychological, and I love thinking about the learning component, but also the biology. And I think, the perinatal period, what makes it so interesting is there's some evidence around sensitivity to estrogen change, which probably, again, I think has a protective role, but it is, that in the immune system. I know my colleague from Johns Hopkins and I are really interested in the immune system and how it relates. So I think there are all these things that we have to figure out that need to come together, and that we have to look at this from multiple avenues, and for each person from multiple avenues. And I'm really glad you brought up I also have had the experience of seeing patients on the perinatal psychiatric inpatient unit who started off with OCD thoughts. And I think over time that was, it's exhausting. And also the societal pressure was really interesting. I think that is a piece that is a really important piece we need to be thinking about. Like, how do we define a mom? How do we, I think all those things go into kind of not being able to let go of those thoughts. But then that is exhausting. And so over time, our system gets exhausted, and we've seen people kind of then actually say the OCD started first and then they went into depression, but then for other people, it may be the depression then, so those are all things that I'm really glad we just need more research and more people coming out like Cindy and talking about their stories, and for all of us to be discussing this. And then postpartum psychosis, I could go on a lot about because I've treated a lot of it. I actually don't know if it's as rare as you say, but I do think it is really important that we have this conversation, that we're having these conversations, that these are different things. But they also are things that we both need to be discussing. And so now we are going to have Stephanie tell us a little bit more about public and patient awareness.
Yeah. So, when it comes to public and patient awareness, something that we see a lot in the general OCD world, and especially in the perinatal OCD world, is that until the professionals, quote unquote, catch up, there probably needs to be a lot of self-advocacy happening here. So I think that's one of the key goals of the public and patient work we're trying to do, is just to make people aware. And, going back to Cindy's story, she literally said, I wish I had known this, and if we just think about the amount of suffering we can save people from, if they're just aware that this is a real legitimate mental health condition that you are experiencing, you're not alone, there is hope, there are things that you can do to get help and feel better. I think that is just going to touch and save so many lives. And then, when it comes to kind of the beyond the patient level, we hear so many heartbreaking stories, particularly in perinatal OCD, about people who are brave enough to share with their care team some of the thoughts they have. Sometimes we get worst case scenarios where, CPS gets involved, or other things happen because people don't really understand that what they're hearing is someone reporting on an obsession or an intrusive thought. So I think that's another big goal we're not quite sure how to tackle, but we will work on tackling that, about how to kind of make the awareness about, in people like maybe first responders and things like that, and, emergency room folks and folks who maybe we don't traditionally think of when thinking about the clinical providers who work with maternal mental health conditions. And I think just the broader overarching goal when it comes to public awareness is just reducing the stigma, just letting people know, I think that's, the goal of any awareness, to be honest. It's not only being able to put a name and a label on what you or your loved one has been going through, but just knowing that you're not alone, knowing that you're not weird for going through this. It's not, your fault. You're not a bad parent at all for living with this condition and with these thoughts and these behaviors. So we're just trying to let people off the hook a bit, I guess, is kind of our ultimate goal in that space. And then just, I did see, I was trying to look at the questions. I saw that someone had asked something about what can non-clinicians do. And I think helping to spread awareness and helping, and thereby helping reduce stigma, is a major thing. Just being aware that this exists in the first place, and maybe even including it in, the work you do in whatever that field might be. You never know who's going to be watching and listening, and who, you might give somebody an aha light bulb moment by learning about this new topic.
Yeah, Stephanie, that was great. And we just need to get the word out there. And I love what you were saying about getting the word out there to all types of people who are interacting with pregnant and postpartum individuals. And I unfortunately have seen cases where people have misunderstood intrusive thoughts. And so really we need to get the word out, and also so that everyone can feel like if they're having these thoughts, that they can have a place to talk about them and to figure out what they need in terms of their health. Great. So now we're going to have Kate tell us about provider work products.
Great. Thanks so much. So I'm going to talk first about core competencies, which Stephanie sort of pointed that out to you on the special section on the website for providers. So I'm hoping you'll check that out yourself as well. But we looked at all professions that are encountering pregnant and postpartum women. And we came up with what we think they need to know about perinatal OCD. And I think the idea is that we don't know what we don't know. And so if we can put that out there, that gives folks some direction in terms of increasing their competence in this space. And so that includes nursing professionals, it includes non-physician behavioral health providers, general psychiatrists, reproductive psychiatrists, community health workers, lactation consultants, doulas, childbirth educators. And then specifically, I want to talk to you and share some of the competencies that we came up with specifically surrounding those who are actually taking care of women during the pregnancy and during the delivery. And so that would be obstetrical providers, midwives, primary care physicians who attend births. Essentially what we're looking for is that they would understand signs and symptoms of maternal and paternal OCD, intrusive thoughts, and the OCD subtypes, that they would develop knowledge about maternal OCD and intrusive thoughts, and understand that that's nuanced from depression, anxiety, and psychosis. That they would learn about the valid screening tools, which we're going to talk about that next, for maternal and paternal OCD, where to locate them and how to use them. That they would recognize the recommended frequency for screening and how to screen for maternal OCD within the scope of screening for other mental health disorders during pregnancy and the postpartum period. That they would understand how to interpret those screening results. That they would understand the critical differences between intrusive thoughts, which may involve a range of thoughts, including suicide, physically or sexually harming the baby, and actual risk of patients with these thoughts completing such acts. That they would demonstrate the ability to assess for safety, including suicidality and infanticide risk versus intrusive thoughts about the same topics. That they would develop knowledge of the menu of risk mitigation and treatment options, both drug and non-drug treatments, and including non-clinical alternative practices. Almost done. That they would recognize which medications are safe to start to continue during pregnancy and breastfeeding when multiple medications are being utilized and when multiple medications may be needed, and when to seek specialized advice from a reproductive psychiatrist. To develop knowledge of how to counsel women with existing OCD who are planning pregnancies and taking medication. And lastly, to learn about and refer to the local network of maternal mental health services where there is expertise in treating maternal and paternal OCD. So those are the core competencies. The other piece of this is that we came up with some screening options. We looked at the different screening options that are out there. I'm going to plug John because I love John's OCI 4. It's 4 questions. And we love that, right? Because time is of the essence. Time is money. It's easy to use. There are some other screeners that are listed on the IOCDF resource page. I can post that link into the chat for folks so that you could take a look at those. And it goes through, describes the measure, how to use it, cutoffs, and things like that. So that's there for you to use.
Great, thank you. That was great. I'm so excited that about this, and I think having this like really concrete things to help people understand what they need to learn is going to make it make this possible to get this out to all those different provider types of people who interact with pregnant and postpartum women, and also help getting people get treatment, because this is something that is very treatable, and we need to get people the treatment, both medication and therapy like ERP. So now I would just we're wrapping up, but I just wanted to see if there anything else that we want to make sure our audience would be important for them to know.
I think one thing we hear a lot about people who are newer to OCD and newer to the treatment of it, and I'm curious if John or Kate is going to have anything to add on to this after I say it. But when it comes to I think a really key thing for clinicians and people making assessments to keep in mind is that whole ego dystonic factor, in that nobody wants these thoughts. Nobody's enjoying these thoughts, but they feel they can't stop them or control them. So I think that's a really important thing. And then on, the patient or the client side, I think it's important to know that we acknowledge that it is kind of a really hard treatment to do, ERP. I don't think anyone would say it's a walk in the park. But there's so much science behind it. It does help so many people, helps the majority. I always hear clinicians say they love working with OCD because it's one of the few mental health conditions where we have a treatment that works, and it really, really works for most people. So once you're plugged into the right place, do the hard work, and you will come out the other side just feeling back to yourself and being able to live the life you want.
Yeah, that's really true. And just to piggyback off the first thing you said, OCD plays a very dirty trick on its sufferers, in that it goes after the things that the person cares about and loves the most. Those are the things that we're most vulnerable about. If you think about it, the things that we care about the most are the things where we feel most vulnerable. So, you have this pregnancy, or you have this new baby, and let's face it, babies come out and they look so helpless, right? And we're responsible for them. And one of the things that we're looking at research-wise is this more for firstborns versus, parents that have had multiple kids and have gone through this experience. But OCD plays upon whether you have, whether it's pregnancy or not, perinatal or not perinatal OCD. And so, it makes it even more difficult to be able to kind of dismiss these thoughts as senseless. I just had this baby. Why am I having these terrible thoughts? And yeah, OCD is like a con artist. It makes you think you've got to do something, to reduce the anxiety. Otherwise, something really bad's going to happen. And of course, con artists they walk away with the money here. And in OCD, the more you do these behaviors, right, as Cindy and Stephanie and Kate also were talking about, the more you do these behaviors, it just makes those obsessions worse. It's fascinating. It's one of the reasons that, people like Mary and I dedicate our careers to studying this stuff, because it's fascinating.
Yeah, I love that about thinking about that. It really is tricky. It's like trying to keep you stuck in it, but it also is that it is, I think that's really helpful for people going through it to understand that it is really about targeting things that you care about, because you do care, and because you are, you are a good mom, you are a good parent, and I see we have a question. So I think we have a little time. So I will try to unmute that person. So Carly.
We actually are only taking questions from the audience in the Whova app, but we can finish out with the panelists here. Mary, thank you so much.
I had one more point to add, is that 2020 Mom, in addressing this OCD and screening, and as Stephanie had mentioned, the OCI-4, we just issued our most recent screening brief for maternal mental health disorders, and including in there, we have screening for OCD, which is great because we want people to recognize that there is something you can do about it. So we have the OCI-4 in there, and then also the OCI-12 from Dr. Rumowitz.
Yeah, thank you. I love that we really have concrete ways that we can get this conversation going in clinical settings, and we need to continue to work in getting the word out.
Yep,
yeah,
and that's both in the Whova app and on our website. So if you want to look there.
I was gonna just add, yes, so important if you're in a position to be screening, expecting parents and new parents for this. So important to normalize the experience, because otherwise, lots of folks they don't want to talk about their intrusive thoughts, because what I think, Cindy, you alluded to this. What if I tell my doctor that I'm having thoughts about harming the baby, and they lock me up or something like that? There's just so much misinformation. It's just so important to, be careful but screen. It's so important to screen.
Great. I think that's a great, is there anything else that anyone wants to make sure we get out there?
I want to say, for folks who aren't trained in providing ERP, because it takes extensive training and lots of consultation to be effective and competent in this area, that there's still things that you can do, and you can the most simple things are to provide the psychoeducation about that OCD cycle and how it's maintained, and to help folks understand why ritual prevention will help them feel better. And for you yourself as the helper to not get pulled in to the reassurance piece. It's so hard, right? Because there see people in distress in front of us and they want us to reassure them that everything is going to be okay. But that's something that you don't have to be trained in ERP to do and to do well. And it is helpful to folks until we can get them, to an ERP provider.
Yeah, that was really helpful. I think, this really is a team approach. I think in terms of, all the team of people that are getting the word out, getting destigmatizing, getting people connected to care, but also giving similar language around these things. And I know it's very easy to fall into that sort of becoming as I like to say, the checking the doorknob. I become the checking by saying, oh, things are fine. It'll be fine. You'll be fine. But also we want people, I do want to, end on that. This is treatable, and this is actually this journey. I've seen so many women come out of this journey actually feeling even stronger and feeling, feeling even more like a good parent. And so I think, we want people to have hope, but also we need to have the same language about, helping get people the right treatment.
And I know that this therapy sounds like, some horrible thing. I know maybe some of you are watching this thinking, how can you take these people? They're so vulnerable and you're exposing them to their fears. If you understand what Kate is talking about in terms of why we're doing this and how this is helpful and the effects that it has, it makes a lot of sense. But don't take our word for it. You can go to Google Scholar. Anyone can do this. Type in exposure and response prevention for OCD. There are hundreds of studies that have been done since the 1960s. This is the best treatment for OCD. And it doesn't take very long, actually, a couple of months or so. And folks have learned that they don't have to be afraid of their thoughts. It's really a powerful treatment. Again, science shows it. Don't take our word for it.
All right, that's great. So I think Joy is going to have you all do the end of session.
That's right. Well, thank you all so much. And John, I think we actually can take your word for it. You guys are the leaders and the leading researchers in the space. So thank you so much for your years and years of work, to both you and Mary for moderating the panel, Stephanie at the International OCD Foundation, incredible work and incredible learnings that you're posting on your website for the world to see now. And of course, Kate and Cindy being clinicians and a patient and a project manager for this important work. Just thank you so much. It was a delight to get to watch and learn from all of you. And really, you emphasize that if we wish to do no harm in maternal mental health, that we have got to get it right with screening, diagnosing, and treating maternal OCD. So thank you all very much. Now we get to put up our poll everywhere poll and invite all of you to type in pollev.com/2020mom and type in the keyword or phrase using an underscore between words that resonated most with you in this session. Everyone has intrusive thoughts. Exposure, screening, self-empowerment, hope, eye-opening. For many of you, even clinicians, this may have been the first time you really understood maternal OCD and intrusive thoughts and ERP, exposure response prevention therapy, as the gold standard for treating OCD and intrusive thoughts. Normalizing, not alone, hopeful hope, awareness, screening. Well, on that note, and somebody else saying, as a perinatal OCD survivor, let's all start to raise awareness. We would love to get in touch with you, whoever wrote that. You know how to find us at 2020 Mom. Thanks again to our panel. It was a delight to hear from you. And thank you again for all your contributions to the 2 years of work in this space.